Okay, that's fine. So we will direct the question maybe to Dr. Adari. The use of anti-seizure medication, um, the use of anti-seizure medication people who have cerebral venous thrombosis without having seizures at all. So what do you think of that?
Um, so technically, we don't have any strong evidence to say we can use anti-seizure medication prophylactically for those patients. If you work in a center where you don't have like a 24-hour EEG coverage or just like limited EEG coverage, and I cannot be 100% sure, level of consciousness of the patient is down and I cannot rule out non-convulsive, in that situation, I would be comfortable to start empiric anti-seizure. But otherwise, if the patient is awake, alert, I probably wouldn't.
So another question here, there is a question about the indication of combining antiplatelets and anticoagulation in patient with ischemic stroke, like you use both agents.
So again, as a neurologist, from stroke perspective, we usually do not combine aspirin and stroke. I know some expert opinion, they would do it if they thought there is a significant intracranial athro, they would do a short term of both. But again, the risk of bleeds with those usually tend to be higher. The benefit is not 100% proven for those, especially after having like those a trial with WASID, warfarin versus aspirin was so the one indication that I would emphasize on again is just if a patient is going to go for carotid endarterectomy, in that situation, vascular and we as stroke neurologists also, we like to combine those two. So yes, that's actually one of the challenges now, especially with COVID, and patient is pro-coagulable. So they will get the STEMI, they will get the stent, and then they will get the stroke, and they want everything. Especially if they had like an unfortunate rapid AFib immediately before to go to their CAT, which is an actual patient that we have right now. So we have to balance everything out, right? So what I would recommend in that time period, if I'm going to do the anticoagulation only for AF, not for any other indication, I would follow the rule of 4 to 14, depending on the severity of the stroke. The antiplatelets, I will be more comfortable with it. I would do the dual antiplatelet. That's okay for me. And if I want to start the anticoagulation, then I can start, depending, of course, on the choice of anticoagulation, I can add it later on in the future. I wouldn't have necessarily like a no, but it will depend on the size of the stroke. Like if I had a malignant MCA and I would usually have stopped there for like 2 weeks and this patient have had hemorrhagic transformation and I want to do all that triple therapy, I still can, but I wouldn't feel very comfortable to do it acutely. So that means I'm just going to delay the time of anticoagulation because cardiac stent will win over and we still need to do the dual antiplatelet for those.
One last question before we break. There is a question about the use of anticoagulant, like after stroke, within the period of 4 to 14 days, for someone who already has received TPA. So would you do that? That's the question.
Yeah, that's similar to one of the studies I showed that they did not find there's any increased hemorrhage if you stick with that rule for patients who have received TPA. Remember, TPA is a short acting. It doesn't last in the system for a very long time. Just those patients who have received TPA tend to have a higher risk of hemorrhagic transformation. So you just want to make sure that you have a frequent follow-up imaging and clinical assessment to make sure that they don't have a significant one. And accordingly, you will just give the anticoagulation.
Okay, one more question by Dr. Jassim.
Now, two scenarios actually which are very difficult. Intracerebral hemorrhage, patient with intracerebral hemorrhage, and you want to anticoagulate for a reason. For example, like a mechanical valve. So how the intracerebral hemorrhage will when do you start anticoagulation in a patient with intracerebral hemorrhage, especially when those people have a thrombus in their heart sitting in their atrium or intracerebral hemorrhage? Please, if you can update us on this.
So another unfortunate encounter that we also have had quite a few of those with COVID. Again, we don't have a clear guidelines. We don't have a clear RCT to tell us when we can start anticoagulation or antiplatelet for those patients. The best we have was START, which tried to look into antiplatelet after ICH, and they thought it would be appropriate to start them after, I think the median was 4 days for those patients. Regarding anticoagulation, you kind of want to wait for at least a month, but if the indication is something that's significant, it will depend on the size or the volume of the hematoma that they have, the location of that hematoma. If I can do a CTA to predict if they have like a leaking vessel, so that will just increase that hematoma from expanding further, I would do those. I would still start them as early as the size would allow me to. If I needed them to be started earlier, what I would do at that point is just very frequent imaging for those patients. I will avoid them to be like super therapeutic if they were started on low molecular weight heparin. Like I would just do a low target for them instead of that time being. And we'll see where it goes. But there is no absolute right or wrong answer. It's really just a matter of balance between the two.
Okay. Thank you very much. I would like to thank all of you for staying with us until this time. Let's reconvene at 1 o'clock. We'll have the satellite, the interesting satellite symposium at 1 o'clock about emgality. So please join us back at 1 o'clock. Thank you so much.